All right, so we have a lot to cover. Let's go ahead and get to it. These are my disclosures, none of which are directly pertinent to this talk. So if after this talk, you're better able to recognize the common pulmonary manifestations of connective tissue disease, ILD, you understand the pulmonary complications of common connective tissue diseases, and can list the most common pulmonary manifestations of specific connective tissue diseases, I feel like I would have been successful. All right, so a little bit of 101 for connective tissue disease. As you all know, or most of you know, connective tissue disease is an autoimmune disorder characterized by the presence of autoantibodies. It really requires autoantibodies. And it can damage the whole body, right? Any connective tissue disease, process within the body. Lung disease and connective tissue disease is quite common. Based on data, it shows about 15% of all interstitial lung diseases are related to connective tissue disease in white patients and up to half in black patients. In connective tissue disease, up to 40 to 60%, so I just say 50%. 50% of cases have ILD, specifically in the setting of systemic sclerosis, myositis, and mixed connective disease, a little lower in some of the other connective tissue diseases. If you have connective tissue disease, ILD, unfortunately, oftentimes it's asymptomatic. We have a lot of patients who are walking around with, some would say subclinical interstitial lung disease, but I don't think it's subclinical. It just hasn't presented yet because people have a lot of cardiorespiratory reserve. So as radiologists, now that we're doing more imaging, it's on us to try to identify these patients early on, considering there are treatments now. In a minority of patients, interstitial lung disease may actually be the first manifestation of connective tissue disease. In up to 20-30% of cases in myositis and rheumatoid arthritis specifically, though this also occurs in other types of connective tissue disease. Obviously, if you have a known history of connective tissue disease, this is the most helpful thing to identify someone with CTD-ILD. You identify some interstitial lung disease on CT, they already have a diagnosis of, say, RA or systemic sclerosis, then you know that you have a patient with CTD-ILD. You don't really need to biopsy those patients. And if you need to image these patients, as we all know, CT, HRCT in specific, is really the gold standard way to image these patients. So I am not a rheumatologist, and I'm not an expert on autoantibodies, and you guys probably don't want to hear me talk about autoantibodies, but I think that I'd be remiss if I didn't at least mention these autoantibodies, which are some of the more specific ones in specific connective tissue diseases. For example, in rheumatoid arthritis, we have anti-CCP. Mixed connective tissue disease, you have anti-RNP. The myositis, we're looking for anti-Jo1 antibody. Systemic lupus, erythematosus, we have anti-double-stranded DNA and anti-SM. And Sjogren syndrome, we have our anti-SSB as well as anti-SSA. So what are the connective tissues we're going to try to cover in the time allotted here? These are listed here. Some of these we're going to spend a little more time on, specifically the first few. And the other, the ones that are kind of later in this list, we're going to spend a little bit less time on because usually they're not going to give you a real CTD-ILD pattern. They're just here for completeness sake. So before we go into any of these specific connective tissues, let's just kind of go over the manifestations, the overall manifestations of connective tissue. What are you looking for? You're looking for, in the lungs, usually some sort of interstitial, idiopathic interstitial pneumonia pattern. So NSIP, nonspecific interstitial pneumonitis, usual interstitial pneumonia, UIP, organized pneumonia, things like that. Patients also can develop pleural effusions or pleural thickening. Airway disease, also not uncommon, bronchiectasis or areas of small airway disease, which manifest as a bronchiolitis pattern or obliterative bronchiolitis. And then in terms of vascular disease, these patients can also develop pulmonary hypertension as well. Okay, so for those of you guys who like to take pictures, this is probably the picture you want to take. So these are the common lung patterns associated with different connective tissue diseases. So if you have RA, the most common idiopathic interstitial pneumonia pattern you're going to see is going to be UIP. You can get NSIP as well, and in this disease setting, also these patients tend to get obliterative bronchiolitis and bronchiectasis. As most of you know, systemic sclerosis, if you have that underlying CTD, the most common pneumonia, the most common interstitial lung disease pattern is going to be NSIP, nonspecific interstitial pneumonitis. With myositis, it's usually going to be this combination, this interesting combination of NSIP and OP. I'll show you a couple examples of that. And with Sjogren syndrome, at least in my clinical practice, it tends to be lymphocytic interstitial pneumonitis. If you look at other literature, actually there's a meta-analysis that was done earlier this year in European Journal of Respiratory Review. And so there, they got all these different studies on Sjogren, and they showed that actually the most common pattern based on the meta-analysis was NSIP. I very seldom see NSIP in the setting of Sjogren syndrome, but based on the meta-analysis, that's what it is. So I'll throw it out there. So if you see NSIP in Sjogren's, It's not uncommon based on the literature, but based on my clinical practice, usually it's going to be LIP, lymphocytic interstitial pneumonitis. All right, so let's start with rheumatoid arthritis. So again, the most common pattern you're going to see is UIP, and you're going to also not uncommonly see airway disease, obliterative bronchiolitis, bronchiectasis, or follicular bronchiolitis. Usually these don't occur together. Occasionally I'll see them occurring together, the small airways disease as well as the UIP pattern of pulmonary fibrosis, but usually it's like one or the other. I don't know why they choose one or the other. I don't really understand the underlying genotype-phenotype relationship there, but certainly it's a manifestation that I see. And again, these other things that we look for, the pleural disease, the pulmonary hypertension, these are things to look for. In specific rheumatoid arthritis, these patients can also develop these rheumatoid nodules, also known as necrobiotic nodules, and I go into that in a little more detail in a few slides from now. So here's a classic pattern of UIP pattern of pulmonary fibrosis and rheumatoid arthritis. This patient has clearly peripheral and basal predominant pulmonary fibrosis, characterized mostly by these areas of subpleural honeycombing, which are lining up in rows and stacking upon each other. It is actually known as the exuberant honeycombing sign. So when can you invoke the exuberant honeycombing sign? It's when the fibrosis that you have in a patient with UIP is comprised more than 70% by honeycombing. So if almost all the fibrosis is honeycombing, you have very little reticulation, very little traction changes, really it just looks like all like honeycomb cysts in there, you can invoke that exuberant honeycombing sign. Now why am I making a big deal about this exuberant honeycombing sign is because that we know in patients who have a UIP pattern and you have the exuberant honeycombing sign, it's much more suggestive of connective tissue disease than idiopathic pulmonary fibrosis. As you all know, when you have a UIP pattern of pulmonary fibrosis, that's usually associated with idiopathic pulmonary fibrosis. So if you have a concomitant finding which tells you, oh, this is not your usual case of idiopathic pulmonary fibrosis, this is something else, might be connective tissue disease, that should make you sort of sit up higher in your chair or like take notice and just kind of slow down. So if you see the exuberant honeycombing sign in setting of UIP, it's going to be much more likely to be CTD-ILD than idiopathic pulmonary fibrosis. What are some other signs that we can see in the setting of UIP that makes you think about connective tissue disease rather than idiopathic pulmonary fibrosis? We have the straight edge sign. So what is a straight edge sign? It's a coronal imaging finding. It's when with a straight edge you could demarcate the areas which are abnormal inferiorly from the areas that are normal superiorly with a straight edge. You see the straight edge sign in setting of UIP much more likely to be CTD than IPF. And here's another sign called the anterior upper lobe sign. Some people call this the four corner sign. I believe back in the day, one of the early adopters of HRCT, one of the godfathers of HRCT, whose name I'm sort of blanking on now, used to call it the propeller sign. And so what is this manifestation? It's really when you have the fibrosis, not just at the lung bases involving the posterior costophrenic angles, but you also have fibrosis in the bilateral anterior upper lobes. And I think this is really nicely seen on the sagittal planes. I really like MPRs for ILD. If you're not using MPRs for ILD, you're kind of handicapping yourself. So much easier to see these patterns and distributions if you use the coronal and the sagittal reformation. So if you have the anterior upper lobe sign, much more likely to be CTD than IPF. Okay, here's a nice example of obliterative bronchiolitis. You might have thought initially that these areas of higher density were just inflammatory ground glass opacity. These are actually the normal portions of lung. The abnormal portion of lungs are these hypodense regions with associated areas of internal bronchial wall thickening. So large areas of mosaic attenuation, which are shown to represent air trapping. And so this is a not uncommon manifestation in patients with rheumatoid arthritis. And so remember, large airway disease, small airway disease, they're like a gang, they run together. And so when you're suspecting their patient may have some small airway disease, look at the internal bronchus, right? That's the large airway within the small airway. And if it's abnormal, if it's dilated, if it's thickened, it's a secondary indication that you're dealing with a small airway disease process rather than something else. Another patient here, this patient also has rheumatoid arthritis, has bilateral pleural thickening with this beautiful example of rounded atelectasis in the right lower lobe. Patients can also develop pleural thickening, pleural effusions. We followed this patient with MRI. Why do we follow this patient with MRI? As you guys know, when you have a VIP patient, oftentimes those VIP patients get the worst care, right? And so this was a VIP patient and they didn't want to get any more radiation exposure. So we started imaging this patient with MRI scans, which they paid for out of pocket. And so this is just an example that if you wanted to, you can image these patients with pleural abnormalities with MRI. This is a non-contrast, and then this is arterial phase, and eventually we have the delayed phase here. And what's interesting is on delayed phase, as you would suspect, the pleural thickening starts to enhance more the contrast gets in there. The round atelectasis also starts to enhance more over time. So if you ever want to do this for your VIP patient in an inappropriate manner, you could do this as well. Okay, another example here. This patient also has rheumatoid arthritis. Nice example of peribronchiolar inflammation. And so this manifests on CT as these areas of central-lobular nodularity, patient with follicular bronchiolitis. This case was shared with me by Dr. David Lynch. And here's those necrobiotic rheumatoid arthritis nodules that I mentioned earlier. So you can get these small cavitary nodules in the peripheral portion of lungs in patients with rheumatoid arthritis. Very often they'll cavitate, so about half of the time, and oftentimes they'll coexist with skin nodules, necrobiotic nodules, for example, on the extensor portions of the arm. So oftentimes when I see this in someone with rheumatoid arthritis, I'll actually call the clinician and ask them, do they also have skin lesions? Do they have also like necrobiotic nodules along their skin? And so then oftentimes they'll have to go back, they'll have to examine the patient, and it's about 50% of the time. It says 80% coexisting here, but I'm sort of like, I'm batting like 500 here. When I ask them, about half the time they'll say, oh yeah, there are some skin lesions. I didn't really know what those were, or I kind of blew those off, and now then we know what those are. All right, so that's rheumatoid arthritis. Now I'll talk about systemic sclerosis. The nice thing about the rest of the connective tissue diseases, so if you wanted to be lazy, you could just think of it like this. So if you have a connective tissue disease and it's rheumatoid arthritis, usually it's going to be UIP. And pretty much everything else is going to be NSIP or some sort of like spin on NSIP, right? There are obviously like nuances there, which we're going to go into in the rest of this talk. But if the main takeaway for CTD is probably that. So RA, UIP, everything else you can kind of think of NSIP or some variant of NSIP. So systemic sclerosis, when you get it, it's going to be NSIP almost always, at least in my clinical practice. So I do see some UIP as well in a minority of patients. And the prevalence of systemic sclerosis having ILD is variable, very variable depending on what paper you read. Some people say as high as 90%. I think that's probably a little bit high, but it's quite common in this setting. As you all know, these patients can develop esophageal dysmotility, and that's going to manifest as esophageal dilation. I'll show you an example of in just 1 second. Also, another manifestation here, I think that's under-recognized, is actually lung cancer, especially the adenocarcinomas. And so we've noticed, at least anecdotally, and I think the literature does support this, in patients with systemic sclerosis ILD, they're more susceptible to develop these small adenocarcinomas than perhaps other types of CTD ILD. And because systemic sclerosis has an NSIP pattern, which looks like ground glass opacity mostly, finding these small ground glass nodules growing within those areas of NSIP can be quite challenging. So I just want to show you a couple of examples so that's in your working memory. So here's a classic example of a fibrotic NSIP pattern. On the left hand, we have a regular axial image. On the right, we have the MINIP. The MINIP is great for bringing out the traction bronchiectasis. Really just, I love how it sort of brings that out. It's really beautiful to me. And so in addition to the ground glass opacity and reticulation and traction bronchiectasis, we have this massively dilated esophagus with internal gas fluid level. We know this patient has esophageal dysmotility. They just have to, given the size of that esophagus. And it's a classic example and appearance, phenotype of systemic sclerosis. Another example here, patient with systemic sclerosis. Again, note the dilated esophagus. It's not quite as dilated as that last case, so not quite as striking, but clearly it is dilated. But here we see another manifestation of NSIP in someone with systemic sclerosis. We again see ground glass opacity with a little reticulation and some traction bronchiectasis. But here the distribution is quite interesting. It's basilar, but there's clear subpleural sparing. I mean, this is beautiful. And this coronal plane, again, if you're not using NPRs for ILD, you got to do it. It makes your life so much easier. This subpleural sparing just slaps you in the face. So I don't know what's happening with the subpleural sparing cases. About 10 years ago, I used to see a lot of these subpleural sparing cases in my clinical practice, but nowadays I don't see them anymore. I suspect they're all being picked off in the community, which is great. So the cases that eventually trickle down to me, they're kind of harder cases, and so it's a good thing, but it makes my life a little bit harder, but hey, and I chose my path, right? So anyhow, this is a classic example of NSIP. NSIP almost always basilar predominant. You know, I've seen maybe, you know, I'm gonna take a step back. It's always basilar predominant. I've seen one case of NSIP that's not basilar predominant, and that was a weird case. A patient with sort of familial pulmonary fibrosis. So I think you can sort of hang your hat on that statement. NSIP is always basilar predominant. UIP is usually basilar predominant, but can have a variable zonal distribution. So NSIP always basilar predominant. When you have this subpleural sparing, extremely specific for NSIP. And NSIP is strongly associated with connective tissue disease. Again, it has its own differential diagnosis, but the first thing you should think about when you see NSIP is connective tissue disease, so that subpleural sparing is a quite powerful finding. How often are you going to see subpleural sparing in patients with NSIP? Depends on the paper, always depends on the paper, but it seems based on the literature, it's somewhere in the 30 to 50% range. In my clinical practice, again, I think it's much lower, it's like 20%, because again, I think most of these cases are being picked off in the community, and that's a great thing. Another patient here with systemic sclerosis, NSIP. Admittedly, this is not as pretty. This CT scan is actually taken from a PET CT, and so you probably already know where I'm going with this. And so there is some oddness here, right? There's obviously some consolidation, ground glass opacity, but there are some areas with a little bit of convexity. For example, here in the left lower lobe, that is suspect for sure. That looks weird. And on PET imaging, this FDG avid, that turned out to be an adenocarcinoma. And so sometimes in these patients with systemic sclerosis, ILD, NSIP, these little lung cancers, almost always adenocarcinomas in my clinical practice, they start to grow. So you got to have your thinking cap on. Here's another one. This is an obvious lung cancer in the right lower lobe, clearly FDG avid in someone with underlying NSIP in setting of systemic sclerosis. But patient also had this in the left lower lobe. So bilateral disease, synchronous tumors here. This was slowly growing over time. We ignored this because this was so conspicuous. The patient actually had bilateral adenocarcinoma. So when you have these patients with systemic sclerosis, ILD, have your thinking cap on. Look carefully for slowing areas of nodularity, especially with convex margins that are increasing over time. All right, now let's talk about myositis. So these are the inflammatory myopathies of polymyositis, dermatomyositis, and their cousin, the antisynthetase syndrome. And so these patients, when they present initially, very often will have this interesting combination of NSIP, non-specific interstitial pneumonitis, which you guys already know what it looks like, and combined organized pneumonia. And I'll show you a couple examples in a little bit. After treatment, these patients will evolve into more of an NSIP pattern. The Jo-1 antibody, as I alluded to before, is quite specific for this myopathy. So here's a patient in presentation. We see this basilar predominant consolidation and ground glass opacity. And so this actually is the manifestation of combined NSIP and OP. So the ground glass opacity is the NSIP, the consolidation is the organized pneumonia. An under-recognized finding, manifestation of organized pneumonia, especially at the lung basis, is this perilobular consolidation. I think you can see that quite well here on the coronal reformation. So this perilobular consolidation. And so that's been described, to my knowledge, just once. I think in AJR, this was like at least a decade and a half ago, by one of the Asian authors or one of the Asian research teams. But I find this to be quite specific, especially in drug-related organized pneumonia, but certainly we're seeing it here as well. So these patients, after they're diagnosed, they get corticosteroids, and 6 weeks later, the organized pneumonia consolidation melts away, and you're left with this more NSIP pattern. This is very, very characteristic. Another example here, patient on the left at baseline, we see combined ground glass opacity and consolidation, this combined NSIP-OP pattern. Patient's corticosteroids, 8 weeks later, patient comes back, organized pneumonia melts away because it's so corticosteroid sensitive in most cases, and you're left with this NSIP pattern. Okay, that now allows us to talk about systemic lupus erythematosus. The nice thing about SLE, or lupus, is that if all you care about is interstitial lung disease, it's very uncommon for patients with lupus to get interstitial lung disease. They get a lot of other thoracic manifestations, but interstitial lung disease is not common at all. If you read the meta-analysis, you read the papers, there's always sort of descriptions of it. And so the meta-analysis that came out earlier this year, they say 5% of lupus cases have interstitial lung disease. That's too high. Maybe it's 1%, right? If that, right? I think it's quite uncommon. But these patients with lupus, they do get serositis, so they can get pleural effusions, they get pericardial effusions, they get pericardial pleural thickening. Patients can also very commonly develop pneumonia. In fact, pneumonia is the most common finding in this disease setting. Patients can develop pulmonary hemorrhage, shrinking lung syndrome, antiphospholipid antibody syndrome, which I'll go into detail in just a little bit. Okay, so here's a patient with bilateral pleural thickening, as you can see, patient with lupus. It's a pretty common manifestation here. We look at the pericardium, there's also pericardial thickening. So examples of chronic serositis or healed serositis. Here's another patient with lupus. I remember this case. So this patient came in for a PN lateral radiograph. I'm just showing the PA radiograph here. And so I called up my technologist. I knew the technologist who took this image. She is wonderful, right? She's got like slight OCD, which for a technologist is a good thing. And so, she sent this to me, and I said, why didn't you have the patient take a good breath? And she said, this is actually the second image. We really tried to get the patient to take a good breath. So because of her OCD, she brought me into the room, right? And so she said, can you help the patient maybe take a better breath with some coaching? And so we tried, but this is the best we can get. And it turned out, at the time, I didn't know the patient had lupus. It turned out the patient had lupus, and so this is known as shrinking lung syndrome. So some of these patients with lupus, they develop profound diaphragmatic weakness, and so they can't get that diaphragm to flatten out. And so this is as good as we could get. Here's a patient with lupus with pulmonary hemorrhage. So on radiograph, there's nothing really to talk about other than diffuse pulmonary opacities throughout the lungs. On CT, we see these areas have a central lobular or sort of centroacinar distribution, right? Ground glass opacity, this patient had pulmonary hemorrhage on lavage. So lupus also is associated with that. This patient with antiphospholipid antibody syndrome, which is associated with lupus, patient had diffuse ground glass opacity throughout the lungs, clearly pulmonary hemorrhage, but then also had hypercoagulable state. You see these dilated collaterals within chest wall. We see these dilated collaterals anteriorly along the internal mammary region in the mediastinum along the spine. So these patients with antiphospholipid antibody syndrome, not only will they bleed, but they can also develop a hypercoagulable state and develop thrombosis throughout their veins. Okay, this brings us to Sjogren syndrome. So Sjogren syndrome, as I alluded before, if you read the meta-analysis, they talk about NSIP being the most common pattern. But again, for me, it's LIP, so I'm going to talk about LIP the most here. Patients can also develop small and large airway disease, but that's not as common in the setting of rheumatoid arthritis. On occasion, rarely, these patients can develop lymphoma, a malt lymphoma, which is most common, and that's going to manifest usually as chronic large nodules, consolidation, which are slowly growing over time, but not as common. And this is the most common manifestation that I see in patients with Sjogren syndrome. It's actually a cystic lung disease. So you see these cysts, which are basal predominant, parabronchovascular and subpleural in distribution. I'll be giving you guys a cystic lung disease talk, I think either the next block of sessions or sessions after that. So I'm not going to go into too much detail here. But bottom line, this is the most common pattern that I tend to see. Also not uncommon to see concomitant nodules and patchy ground glass opacities, as we see here. Because these cysts tend to be parabronchovascular, not uncommon to see is this pericystic dot as well, which is the adjacent vessel. And let's talk about mixed connective tissue disease now. So mixed connective tissue disease is very different from undifferentiated connective tissue disease or interstitial pneumonia with autoimmune features. So I remember as a medical student, I struggled with this. I don't know why I struggled with this, but for some reason, I equated MCT, mixed connective tissue disease, with undifferentiated connective tissue disease, when in fact, mixed connective tissue disease is a defined connective tissue disease. Undifferentiated connective tissue disease is not. Undifferentiated connective tissue disease is essentially like something where people suspect connective tissue disease, but you can't put a label on it. MCTD is an actual diagnosis. It actually has its own profile. It's a distinct clinical entity with overlap of different types of connective tissue disease. In these patients, the most common pattern you can see is NSIP pattern. And here's just a simple example of NSIP, clearly basal predominant, ground glass opacity, and reticulation. And we're not going to go into too much detail about this UCTD, undifferentiated connective tissue disease, and IPAF. This terminology, undifferentiated connective tissue disease, at least in the setting of interstitial lung disease, has fallen out of favor. We're trying to use this new terminology, IPAF, interstitial pneumonia with autoimmune features. But right now, really, it's a research terminology, and we're just trying to label these patients so that in the future we can follow them and see how they respond to therapies and what their natural course is over time. So I won't go into too much detail here. So in summary, we talked about the different connective tissue diseases and their pulmonary and thoracic manifestations. In patients with rheumatoid arthritis, again, we're thinking about UIP. They can also have these small airway disease, so obliterative bronchiolitis, follicular bronchiolitis. Look for pleuritis as well. Systemic sclerosis, look for NSIP and esophageal dysmotility. The myopathies, look for that combination of NSIP and OP. Remember, in lupus, they really don't develop interstitial lung disease, but look for other things like serositis or pulmonary hemorrhage. Sjogren syndrome, LIP is what I most commonly see, which most often manifests as a cystic lung disease, but you can get NSIP as well. Mixed connective tissue disease, look for that NSIP pattern, and in all patients, look for, again, examples of serositis and pulmonary hypertension. I'm really from Chicago. The weather is awesome here in Orlando, but this is just to prove to you guys that in Chicago, we do get good weather. I'm sure you guys, I don't know, most of you guys, when you go to Chicago, you probably come for RSNA, being radiologists, but I guarantee you, every once in a while, about 7 or 8 random days in the summer, we do get good weather. Yeah. So anyways, thank you for your attention.